Good morning, everyone. Let me welcome everyone to the first extraordinary session, or the extraordinary session special for Public Health and Developmental Services. Today is July 2nd, 2015, here in the state of California. Let me also, at this point, welcome all the members to the committee, and I've worked with all of you somehow in some form in either previous committees or in current committees, etc. Also like to, at this time, publicly thank the leadership, the pro tem, for raising the issue with the administration so that we could have this hearing to look at how we're going to address the shortfall in additional revenues. And of course, I'd like to thank the administration and the governor for taking a leadership role to look at the issue of how we're going to come up with additional revenues to deal with here in special session. So I'm here today because we have deficit in financing related to our 2015-2016 budget and must be filled. We also must find a way to make program investments to improve care for Californians. In calling the special session, Governor Brown has indicated the principal purpose is to enact permanent and sustainable funding from a new managed care organization tax and or an alternate funding source to provide, number one, at least $1.1 billion annually to subsidize the general funds costs for Medi-Cal, sufficient funding to continue the 7% restoration of IHSS hours beyond the 2015-2016, and sufficient funding to grant rate increases for providers of Medi-Cal and the developmental disability services. I know that the recent federal rules on the MCO tax have made enacting another one much more complex, but I also know we are in an industrious group. Additionally, I believe health plans to be responsible members of our healthcare system and society at large, so I fully expect that they will be ready to work diligently to find a solution, and I know we've been talking already and they're eager to do so. And I want to thank the Governor Brown for calling this special session that helps spotlight the fact that we have been underfunded in Medi-Cal and DDS for way too long. It was a brave move on his behalf, and I am particularly pleased because there are issues that I've been talking about for close to 8 years. Many individuals may not know this, but the amount a physician gets paid for a regular primary care visit in our state's Medi-Cal program is $16. Let me say that again. $16, the amount a physician gets paid for a regular primary care visit in our Medi-Cal program. That's less than the average pizza an individual or a men's haircut, and less it would cost to buy a big, large pizza from Round Table. This must change. Ranking 47th out of 50 states in payment of per Medicaid enrollment just isn't good enough, especially considering our big states like New York pay twice as much to do the same service. As many of you know, I've been chair of the Senate Health Committee for the last 5 years, and during that time, it's been a privilege to usher in some of the biggest changes to our country's healthcare system since Medicare. I am so proud that California has truly led the way implementing the Affordable Care Act, and being part of that and being chair of this committee during this historic time has been one of my life's greatest triumphs and greatest pleasures. I always tell people I feel like I'm a kid in a candy store being chair of the Health Committee in the right time and right place in history. But I'm embarrassed about what we pay providers to see the patients in the state who need care the most. And more importantly, I'm ashamed about how the inadequate payment affects access to care. And that's access to the most vulnerable population that we have in the state of California, in those areas, whether it's the rural or inner city, and it's those individuals that have the highest need and the highest incidence of conditions like diabetes or high blood pressure. By next year, we expect to have more than 12 million individuals in California on Medi-Cal. That's a third of our state's population. 1/3 of our state that holds an insurance card but still lacks meaningful access to care. Given the dramatic expansion of enrollment in California's Medi-Cal program, it makes no sense to continue Medi-Cal provider rates reductions that limit access to care and that were enacted during California's economic downturn. And yes, I did vote for those cuts. Yes, I did vote to cut optional benefits, but it was my fiduciary responsibility as a lawmaker to follow the Constitution, balance the budget, but at the same time, we now have to be innovative and figure out ways how we're going to restore those and hopefully make sure that everyone gets access to care. Not only is it unfair to the providers participating in disadvantaged communities or to the 12 million Californians struggling to stay healthy without a timely access to care they deserve, it ends up costing us all even more. Medi-Cal and DDS programs in California need to be more than an empty promise. In subsequent days and months, we really need individuals to come to the table with viable revenue generation solutions. I encourage you all to keep your focus on that objective. And with that, I'd like to go ahead and get started. We do have an agenda in front of us. And then before we get started, I'd like to take this opportunity to see if there's any other members that would like to make any opening statements at all at this time. I see and I recognize Senator Nielsen first. Vice Chair Senator Nielsen, I apologize. And
well, Mr. Chairman, thank you very much for the indulgence. And indeed, all you say was wise, and I've appreciated your leadership throughout, as well as Senator Leno's on the Budget Committee. But let's keep in mind a budget just passed. A budget was based on additional revenues that have been available, that are being spent. Some of those revenues, from our point of view, were to have gone to the Medi-Cal provider increases. That didn't happen. That's been punted down to now. And there will be a hue and cry for new taxes, new revenues. What happened this year as we rolled into the budget and the extra revenue that was available clearly demonstrated that a renewal of Proposition 30 is not necessary, and that the legislature is capable and can prioritize without really any disastrous consequences. And keep in mind, and related to the ACA, California has chosen willingly to go way beyond what the federal act requires. That has implications. We have done other things in terms of providing benefits to other populations that also are increasing the impact on our budget. And we must be mindful of that, and we must be mindful that everything cannot be solved with tax increases. So I keep that in mind as we proceed. Thank you, Mr. Chairman.
thank you. And I do need to make another apology. I mean, this is such a new committee. I just learning who's on it, and I apologize. I mentioned you as vice chair. It is Senator Morrell who is vice chair, and he was vice chair when we were in the health committee, but then I lost him, and now I have Nguyen. But anyway, so I've got to figure out who's the vice chair. But welcome, and please make some opening remarks if you like.
Who's on first? Thank you. Thank you, Mr. Chairman. I do look forward to listening to today's presentations from the administration and the LAO. I also look forward to reviewing any and all proposals that come before our committee. That being said, the governor's proclamation convening this session presents legislators with, I believe, a false choice. Republicans do not believe that the only two choices today are A, either to approve a $1.7 billion MCO tax, or choice B, continue to underfund Medi-Cal and the developmental services. While it is that the federal deadline is more than a year away, we are moving to rush a decision in a way that can only drive up the cost of health care by extending more than $1 billion in taxes when we just saw more than $10 billion in increased revenues. As Senator Huff stated during a recent budget debate, a budget reflects the priorities and values of the majority party. So it is worth noting that the recently enacted majority party budget includes things like salary increases for unionized public employees, an expansion of government health care for undocumented immigrants, and therefore, as Republicans, we believe it is our duty to protect the taxpayers. Yet, we did not include rate increases for things like Medi-Cal providers, or we did not adequately fund services for developmentally disabled citizens. So just as we adopted a new budget with new record high spending, $11 billion over 2014, we adopted a budget of approximately $265 billion. And yet today we've taken in nearly $10 billion more than we had anticipated of tax revenue. And so now we've convened a new special section to extend over $1 billion, again, in more taxes to an already vulnerable healthcare system. and an already overtaxed public. So with families already struggling to purchase health care under the Obamacare mandate, it is unfair to tax their plans for a Medi-Cal expansion. These are very questionable priorities. So a special session wasn't needed to address these. So a special session, I don't believe, was needed to address these issues. But all we needed to do was to set the right priorities in our budget in the first place, but yet we sit here today. So in closing, I want to make clear that while my Republican colleagues and I would have chosen a different course, we do remain hopeful that solutions may be found and that some that we may be able to support. Thank you very much, Mr. Chair.
Thank you. I believe Senator Pan had a comment, or did I miss anybody else that raised their hand first? We'll go to Senator Pan, then we'll go to Senator Mitchell. Senator Pan?
Right. Thank you, Mr. Chair. Dr. Chair, first of all, I just want to thank our chair, who eloquently described some of the challenges that we're facing, that we're going to be addressing in this special session. And I also want to recognize the leadership of our pro tem and also our leader, the speaker in the assembly, and of course our governor, in saying that we need to address significant issues regard to our health care system, Medi-Cal, developmental services, and our infrastructure. And I think some of the things to keep in mind as we're moving forward is that we as Californians, there's some reference to the budget, we're actually kind of a donor state when it comes to our federal funds, in terms of our federal taxes. Californians pay more in federal taxes in return. There are opportunities for us to get matching funds related to Medi-Cal and developmental services. We should be taking advantage of that. Those funds, as they return to our state, also help stimulate our economy, because those funds are paying for not only services, they're paying for jobs. Jobs for delivering health care, developing help for our developmentally disabled that are needed services, and that will also help contribute to our economy while ensuring that we take care of many of our most vulnerable. In addition, when we talk about spending, we also need to talk about costs. And for example, there are some things like tobacco that actually has been linked to diseases that actually cost taxpayers, and we should be looking to recover some of those costs that are being borne by the taxpayers of California and from those who have generated the costs to help fund the services that are needed to take care of the people who are suffering as a result of that. So I think when we look at the overall picture, there is much to do, but also that we also need to look at the fact that we also need to ask people to step up and contribute and take responsibility for some of the costs that the taxpayers are bearing in order to be sure that people can get access to services that they need. So again, I want to thank you so much for this opportunity. Thank you.
Thank you. I believe Senator Mitchell, comment?
Thank you, sir. Very briefly, I want to thank you for the opportunity to serve on the committee today, and just say that I look forward to a robust, reality-based conversation about critical issues that you've raised. The whole notion that a doctor's visit in the real world would cost $8 is absurd. And I think we have a responsibility to have a reality-based conversation. And reality is actions that community leaders are being forced to take. The leader of STEP issued a letter to her local regional center June 19th stating that she was no longer able to accept referrals. This is an organization that has successfully placed residents from developmental centers into the community who are living successfully. And so that's reality, that as we do move forward, as was included in the budget, in closing developmental centers, we have, if we don't take action, robust action in this committee, we will compromise their ability to be successful in the community. And again, in terms of reality, just yesterday received, I think this is about 50 note cards and letters from constituents, I'm assuming all of us are having the same experience, calling for full funding for basic care today. And so that's the realities that Californians are facing, and I look forward to doing what we must do as thought leaders in this state to make sure that basic health care needs are met and that people in developmental centers have a place to go once those centers close. Thank you, sir.
Thank you. Senator Leno?
Thank you, Mr. Chair. It's a pleasure to be serving with you on this extraordinary session committee, and I think that one of the reasons I'm here is as budget chair, and I want to follow up on Senator Mitchell's comments regarding the need for us to have a reality-based conversation. We're certainly of different perspectives, representing different parts of the state, so we approach these issues with different constituencies, and that is all right and good as it should be. But again, with regard to reality-based, yes, we've seen a surge in revenues in the past few years, but we are still significantly below revenues and expenditures compared to where we would have been if it had not been for the crisis of 2008. Looking at LAO projections of where we would have been, potentially 10, if not $20 billion ahead of where we are now. So we have not restored funding that we cut from the University of California, from CSU, from our community colleges, from our court system. Our social safety net has not been restored. There are great needs across the state. So that is the reality. And it's easy enough to demonize public employees who did not see any kind of increase in their wages for over a half dozen years. So we begin to get them back up to where they might have been. These are hardworking people who have families and children and responsibilities. When they spend their money in the community and go to small businesses don't look at their dollars differently than those in the private sector. We're all in this together. And so I think it will serve the committee best if we not take some political cheap shots, but just look at the reality of where we are, what our needs are, and how we can thoughtfully and reasonably, looking at a historical perspective. This MCO tax is nothing new. It has sustained California for many years. You're about to dig into it so we can all better understand what it is, how it came to be, and what it provides our state and our state budget. So we're here to learn, and I hope we'll all be paying close attention to the facts and the reality that is presented to us. Thank you.
Thank you very much, Senator Leno. Seeing no other questions being asked, why don't we go ahead and get started, excuse me, with item number 1 under Governor's Proclamation. We're going to start off with Michael Wilkening, Undersecretary, California Health and Human Services Agency. We're going to ask Jennifer Kent, Director, and Mary Cantwell, Deputy Director, Department of Healthcare Services, and Teresa Calvert, Department of Finance. And what we'd like to ask of you is to go ahead and proceed, make your presentation, and then we'll open up to questions to any of the members.
Thank you, Mr. Chair, Senators. Mike Wilkening, Undersecretary of California Health and Human Services Agency. Thank you for having us here this morning. As you mentioned in your opening remarks, we have a situation in front of us where we have the federal government will not reauthorize the managed care organization tax as it currently exists. And since 2005, that has been a stable source of funding that has helped to pay the state's costs associated with providing health care. We also need a stable funding source for restoration of the 7% reduction in IHSS hours. The general fund in the Budget Act of 2015 is paying those on a one-time basis, but we need a stable ongoing source to pay those for those hours. Together, those two represent about a $1.3 billion pressure on the state's finances. The governor called the special session to enact the permanent sustainable funding from either a new MCO tax and or other alternative fund sources, both to replace the existing MCO tax, to restore the 7% reduction in IHSS hours, and then also to provide additional rate increases for providers of Medi-Cal and developmental disability services. It's important that as we go through the special session at the end, that the enacted revenue is sufficient to cover any increased expenditures that we have coming out of the special session as well. And that for Medi-Cal rate increases, we want mechanisms to ensure that the additional resources result in expanded access to services. And that with rate increases in DDS, if there's a need for increased oversight and effective management of the services that are provided through the regional center system. I have with me today Teresa Calvert from the Department of Finance, Jennifer Kent and Mary Cantwell from the Department of Healthcare Services, They can provide any additional information on the mechanics of the MCO and how it's been utilized. We also have Director Santi Rogers and Chief Deputy John Doyle from the Department of Developmental Services here who can address any issues that arise in that system. And Will Lightbourne from DSS who can address any issues that you have relative to IHSS. Again, I'd like to thank you for having us here this morning, and if there are any questions.
Thank you. Why don't, yes, Senator Morlock.
Just in maybe layman's terms, could you explain the federal government's process and where did it come from and why are we doing a matching type of program? Why doesn't the federal government just give every state a per capita, make it simple? And how did this originate and how do I explain it to constituents?
Are you talking about the overall Medicaid system and how the federal government?
No, just this component of the MCO. And your opening remarks said the federal government is making a change in the Medi-Cal payment structure. So how do I just put it in layman's terms to explain to the public what we're actually dealing with here?
I'll let Mary do the translation into English for you.
Thank you.
Although I'm not sure with this, oh, sorry.
Real quick, we will have that presentation of the LAO as well, but I'll have.
I can wait.
No, we can still have her explain it, but the LAO is going to kind of explain up with what the MCO is, but by all means, go ahead.
Sure. So honestly, I think it is a little bit hard to probably explain in the normal public who doesn't track these things. Essentially, we're allowed to fund the non-federal, so the state has to put up money in order to draw down federal money for the Medicaid program. One of the ways in which the federal government allows that is it does allow states to assess taxes on providers, and that includes health plans. But there are particular rules that indicate you can't sort of do that to try to just game the system and have it just be a way to get additional federal money that isn't really about making a fair distribution of Medicaid funds. And so the fact that we have a tax today that only taxes our Medi-Cal plans means that there's no actual net cost to the state. It just is bringing in additional federal money. And what they require on provider taxes is that they be broad-based and across a broad array of providers that provide both Medi-Cal and non-Medi-Cal services, so that it's a real tax and a real source of funding for the program.
And where does that originate from? Why go through the hoops and all these gyrations when the federal government, it's sort of like our money anyway, right? We paid it, they got it, they can send some back.
So it's from federal law in terms of the Medicaid program having to be a matching program.
So this happened in what year?
When Medicaid was established in 1965.
So it's always been that way.
Yeah.
Okay. Then and then IHSS. How does that fit into this? What's the nexus?
So IHSS is a Medicaid benefit. So it provides in-home support for people who are Medicaid eligible. And there was a reduction in the service hours during the reductions several years back. And we had a settlement agreement on this where we're going to look at ways to restore those hours. We did an across-the-board reduction in the number of hours that people had. So if you were assessed for a certain number of hours, then we reduced that by 7%.
And so in Orange County, we sort of relied on the minimum wage to be the threshold for what we were negotiating with our IHSS employees. And so if the minimum wage goes up, then their wages go up. Mm-hmm. Is that correct?
This is actually in the hours that are on the recipient side. So a person is assessed for a certain number of hours that they need under this program to provide in-home support. And those are the hours that were reduced. So the number of hours that a recipient would receive. So it's not tied to the wage rate that's paid to the provider. It's instead the number of hours that a person would receive under the program.
Well, then I'm trying to figure out, with an increase in the minimum wage, which was approved, does that mean that you're going to have to find more funding for that, or are you going to reduce the hours more?
It means that the cost of the program goes up. So if the cost of providers goes up, then the cost of the program goes up. And so
So there's an impact on other votes that we make as
Yeah, so either,
legislators.
and that's we adjust those as we go through the budget deliberations. So there's an adjustment in the budget to account for increases in wages that have been negotiated.
Okay. Thank you, Mr. Chair. Thank you very much.
What I'd like to do, if we don't mind, is we can hear the entire presentation and we have everyone ask questions after, so that if during the presentation it could answer most of your questions, and I'm not trying to stifle any conversation, but and then by all means follow up. If you guys don't mind, we can do that first. Okay.
Mr. Chair, I apologize. I thought he was done. He said any questions, and I thought he was.
It may be helpful.
So I apologize.
No problem.
We'll do a brief overview of how the MCO works.
Right.
Jennifer Kent will do that, and then perhaps you can react to that.
And let me just kind of lay out the purpose of this first meeting is to do exactly that, to kind of learn from all the various agencies. We're going to have LAO, talk about, cost, and then talk about if we were to increase the rates, increase the developmentally disabled, how do we address this? Perhaps the additional costs for IHHS. What is that total dollar? And then we need to decide, okay, if we're going to do that, where is that dollar coming from? Is it additional revenues, whether we agree or disagree, or is it through the current budget? So, but this is just sort of an overview, and then by all means, we'll allow anybody to ask as many questions as they want. Anyway, Ms. Kent, please proceed.
Sure. Jennifer Kent, Department of Healthcare Services. I'm the director, and Mary Cantwell, that you've already heard from, is the state's Medicaid director and chief deputy. A little bit of overview as to how the managed care tax was initially started in California. There was congressional allowance for a few states to tax their managed care organizations for Medicaid back in 2004, 2005. And so we and maybe 2 or 3 other states had a managed care tax in place, and then that, and it was at 5.5%. That was eliminated by federal action, and so as that tax was coming to an end in 2008, 2009, kind of at the start of the recession in California, the state was making severe reductions in a lot of different programs, and there was a proposal to restart that tax in a slightly different way for the managed care plans through the gross premiums tax, which is a constitutionally authorized tax over on the Department of Insurance. And so that was, and that's at 2.35%. And so we, as a state, enacted that tax in place of the previous managed care tax. So it was a lower tax rate. But what we did was we applied it only to Medi-Cal plans and their Medi-Cal revenue. And what that did was it allowed for there to be a non-federal share to support the continuation of the Healthy Families Program, which at the time was the cut that had been made. And the plans worked together with the legislature to secure a 2/3 vote. The tax was on, they were taxing themselves in order to save that program and to save their funding and obviously save their own business on that side. When the state made a change from the Healthy Families program over, and we moved those Healthy Families recipients over to Medi-Cal, the tax and the plan's authorization of that tax came along and was reauthorized. Each of these taxes obviously have had time-limited terms on them, so that there's been always a revisitation of the tax. And then I believe it was in 2010, 2011, there was a change from the gross premiums tax to a sales tax on the plans, again, always limiting to the Medicaid revenue, and that increased the amount of money that was generated, again, with support from the plans. And we were using that revenue, obviously, always going back in as the general fund portion to support managed care rates. Medi-Cal's a big program. And then we received a letter last summer from the federal government, which Mary can certainly detail, but it essentially said to states that had enacted these kind of managed care taxes was, you are regenerating money. There is no harm to the tax payer in this case. And provider taxes have very basic rules, which are, and this is maybe your best explanation for the regular person on the street, is there has to be winners and losers. And in our tax today, there's no losers because the individual or the plan paying the tax receives that tax back through their rates in our administrative component. And so this broad-based tax makes, it's a requirement that there have to be people that win and lose. And so this is where we are today is We would obviously find it a lot easier to continue things the way they are, but with the federal guidance, we are going to have to change. And so that has been the very distinct difference between all the taxes that have been done to date and where we are this minute. And I think, just to also put in perspective of how Medi-Cal is funded today is there's about $18 billion, and I'm rounding, so don't quote me, but about $18 billion in general fund. The Medi-Cal program's total budget is around $95 to $96 billion. And so when you think about the general fund component of the overall program, we're a 50-50 matched program. And so we're clearly not, as a state, from a general fund perspective, paying 50% of the costs of the program. And, a lot of those other funds that we use, managed care tax, there's a hospital tax, there's a nursing home tax, there's a lot of county money in our program today. And so that's what makes up the total budget of what Medi-Cal authorizes. I think we have, and to Senator Pan's comments earlier in the hearing, I really want to recognize when you spend $95 to $96 billion a year for a program, you're very aware of the economic impacts of what we do. It's not just the fact that we're covering 12.5 million Californians, but we have a lot of providers, a lot of facilities, a lot of meaningful services that we have to fund. Our monthly check write on managed care today is somewhere around $3 billion a month. Our weekly check write and fee for service is somewhere between $300 and $400 million. And so those are very big numbers for a very big program. And so anytime we talk about rates, anytime we talk about increases on those rates, you have to take it back to the magnitude of what we actually fund as a state and as a program. And so there's very meaningful impacts. And the loss of the managed care tax, which is obviously our first priority as an administration, is the loss of about $1 billion in our program is a really significant hit. And so that's why we're very engaged and interested in coming to a solution with the legislature and those that would pay it. So